chance for you, even if chemo, radiation, or surgery didn't work or isn't tolerated. Our goals are best results and quality of life. Meet Dr. Lederman to hit the cancer. For a free booklet DVD, call 212-CHOICES, 212-CHOICES, for a fresh second opinion. Most insurances, Medicare, Medicaid accepted. Not only super convenient, super. Broadway and 38th in Manhattan. To hit your cancer, see Dr. Lederman, 212-CHOICES, 212-CHOICES.
Welcome back to the Radiosurgery Hour. This is Rob Redstone here with Dr. Gil Lederman at the WABC studios in the heart of New York City. We're just a few steps from the Radiosurgery New York Cancer Treatment Center on Broadway and 38th Street. Dr. Lederman, the leading cancer expert, treats prostate cancer non-invasively. He was the first in New York with fractionated brain radiosurgery, and he's the first in America and in the Western Hemisphere with body radiosurgery. Hey, Dr. Lederman, we're back.
Hey, we're back. We're live. We're here. Happy to speak with you if you wish. We're talking about esophageal cancer. So where's the esophagus? It's not one of those sexy organs you see in Playboy magazine, but it's critical. The esophagus is a tube between the mouth and the stomach, and if it doesn't work, you can't swallow, eat, maintain your nutrition. So there's a new report out just this week that shows that people who smoke and drink alcohol are nearly twice as likely to develop esophageal cancer as those with only one of those two habits. So this is a study from Health Day. Previous research has shown that smoking and drinking are risk factors, but this is the first study to show that the risk associated with smoking and drinking is a combined, more synergistic and more lethal habit. The findings were published in the American Journal of Gastroenterology on April 22nd. And the lead authors, Dr. Prabhu, said, our study suggests that not only do alcohol and tobacco play an important role in the development of esophageal cancer, but their combination use increases potency as carcinogens. This year, about 18,000 Americans will be diagnosed with esophageal cancer, and more than 15,000 will die. So you're talking about a death rate of about 80%. So there's lots to do to cut down on the esophageal cancer and lethality. One is to stop smoking, which is so critical, stopping smoking. Number two is early diagnosis for persons having trouble swallowing, getting food down, reflux, burning. Give us a call, see your doctor. And if you have esophageal cancer, call us at 212-CHOICES. You'll speak to the doctor and try to get the most effective treatment, 212-CHOICES. So this is new news, and as bookends, I want to talk about several patients who came in this very week, with esophageal cancer. The first is a 62-year-old married woman. She's from India, been here for many, many years, have 4 children. One of her children is a physician. In April 2011, she was diagnosed with esophageal cancer. She had trouble swallowing and a 26-pound weight loss at that time. She went to most super-duper cancer hospital, and which will go unnamed, and she had chemo and radiation. And then on August 19th, she had surgery, even though the cancer was totally gone. The radiation and the chemo made the cancer go away. She had surgery, did okay, and now comes in with at least a 4-month history of hoarseness. Hoarseness means raspy voice. When you have a raspy voice, it's emergency. So if you have a hoarseness, don't sit on it. So she unfortunately sat on it. Her daughter, the doctor, said it's more than 4 months. She called me yesterday. So the doctor there got a PET scan, and he found a mass just next to the new esophagus and another mass in the lung. And he sent her for laryngoscopy, which is to look in her voice box. Well, the problem is this mass is on the other side of the esophagus. So if you look down the voice box, all you're going to see is the paralyzed vocal cord, which we already know about from the PET scan. So it's not going to help anything. I asked the patient, are they going to be prepared to put a little Teflon in the vocal cord to bulk it up to get rid of the hoarseness? And she said, no, they're not prepared for anything. I said, well, why are you going to just look inside? You're going to be sedated, have a procedure, and they're not going to help you? Doesn't make sense. You already know the vocal cord's paralyzed from the cancer that came back and is pinching the recurrent laryngeal nerve, the nerve that makes the vocal cord move. Doesn't make sense. Why do a procedure if it's not going to help you? So she left the super-duper famous hospital and came to us at Radiosurgery New York, and I took her history and met with her and her son and her husband. Went over the tests, got the reports, got the pathology, spoke to the radiologist, and she was shocked. We spoke to the radiologist, all four of us on the phone, who read the PET scan. I asked him, so where exactly is this mass of cancer that shows up on the PET scan? Is it near where the surgeon cut? And he said it was 5 millimeters away. That's about a 1/4 inch from the surgical incision. And it looks like the other recurrence in the lung is by the other surgical incision. So here was a patient who seems to have recurrence of her cancer everywhere the surgeon was cutting. And she was having symptoms, and they ordered a test that wasn't going to help her. So we took things differently. We saw the scan, arranged her to see a ENT who could fix her hoarseness without doing multiple steps. We talked to her about cancer treatment options, including radiosurgery, so we could treat those 2 sites of metastasis. We offered her biopsies if she wants. We offered treatment, and she seems most interested to shrink down that cancer. She hated chemotherapy. She had terrible side effects from chemotherapy. She hated it. The beautiful part about our radiosurgery is we're able to zero in, treat the cancer non-invasively, no cutting, no bleeding, no hospital stay, no anesthesia. It's all non-invasive. Treatment takes about 15 minutes. Patient lays down, gets a treatment, gets up and goes shopping or goes to lunch or goes across the street to Macy's or goes home or does what they want. And isn't that what you want, to do what you want? No one wants to be stuck in a hospital. No one wants to be stuck getting surgery or chemo if there's better options. So we spoke to her about all the options. Our success rate where we attack esophageal cancer, either in the primary site or metastatic sites, is about 90%. We've treated thousands of patients. She liked what she heard. Her husband liked the attention and the thoroughness, and the son too. That was on Thursday. On Friday, the daughter, who's a doctor, called, told her. And now it's in the patient's hands. And we believe the patient is the president of the United States of their body. And the patient gets to hear all the options. The patient gets to decide. And the patient, hopefully, gets to benefit from radiosurgery. So we wish this woman good luck, easy decision-making, get the voice back, get the cancer shrunk, get into remission, and then we repeat the scans to make sure everything is A-OK. We believe in proving that our work works. Belief is great, but proof is better, data is better. And while we're talking about esophageal cancer, it seems like we have a lot to talk about esophageal cancer this morning. We had a man come in. He's an Italian-American, married to a woman who's from Philippines, was the nurse who took care of his parents, and he fell in love with his parents' nurse, which is a beautiful story. He had esophageal cancer like this woman, and then, despite standard chemo, radiation, surgery, the cancer came right back in the middle of the field. This is called local recurrence. It didn't work. The treatment didn't work. and the mass was obstructing the esophagus. Now, he's told by his doctors there's nothing useful we can do. You should go home and just wait. He heard about radiosurgery options. He came in with his wife just a few weeks ago. We talked about all options. He has a niece who's very involved in the care. She called. We spoke to her. He decided he wanted to go for it, and we went for it. 5 treatments, non-invasive, outpatient, 15 minutes each, no pain, no cutting, no bleeding. When he came to us, he couldn't swallow. He couldn't eat. He could get some liquids down, but he was having trouble with solids. Meats he couldn't do, solids he couldn't do. Now, 2 weeks later, he's eating steak. He's feeling good. He's eating meat. He's eating solid foods. He's happy. His wife's happy. I'm happy because it's great to see the effectiveness of treatment. For him, he was skeptical, which is great. It's good to be skeptical. He wanted proof. We got him proof. We talked about our data, which we compile and work hard at compiling our data. And the proof of the pudding, literally in this case, is in the eating. And the eating is not just pudding, but it's steak and solid foods and hamburgers. He's had no side effects. Wishes to proceed to other sites. He comes to us from Long Island on the Long Island Railroad. We're right close to Penn Station. You can walk over. In fact, I'm over the Penn Station right now as we speak in the radio studio. It's just a short walk to our office. It's easy to get to. It's convenient. No headaches, no parking. It's super convenient. And for this man, it is super. So more good news from the Good News Department, Radiosurgery New York. This is Dr. Lederman. We have more to talk about. We have a lot more to talk about. As I said, we have a booklet and DVD about our work, and you're welcome to call us. We'll mail that out. And if you have a particular case for yourself or your loved one or your neighbor, it's obviously best to come in so we can sit down. And as my grandfather told me 50 years ago to his doctor, come in, close the door, sit down, and let's spend some time together. And that's what we do. We spend time together to get to the bottom of the problem. We're not in a rush. We get the documents, give you copies of them, and then you can participate and understand your own health care. It's not a secret, and you deserve that. So we're going to hear from some old voices, and we'll be back in a moment. And if you have questions, please call us. We're live at the WABC studios, 1-800-848-9222, 1-800-848-9222. Russ is ready to take your calls, and me too.
Here's Dr. Gil Lederman, New York's only Harvard-trained, triple-board-certified radiation cancer doctor. If chemosurgery or radiation isn't working or isn't tolerated, when cancer and its pain and symptoms aren't getting better, seek a fresh second opinion at Radiosurgery New York's Urgent Cancer Consultants for innovative, custom-tailored cancer treatment. See our experts within one business day because we know your time and your life are precious. Our goal is proper diagnosis and effective, non-invasive outpatient treatment. Decades of leadership, first in New York with brain radiosurgery, first in America with body radiosurgery for cancers of the brain, body, and prostate, all custom-tailored for you. Call 212-CHOICES, 212-CHOICES for a prompt appointment and free booklet DVD. Super convenient, 38th and Broadway, with most insurances, Medicare, Medicaid accepted. You're next at Radiosurgery New York. Just call 212-CHOICES, 212-CHOICES.
You know, cancer, it's not prejudice. It strikes everyone. We've seen the racists with the big C. We've seen humanitarians struck down with the big C. But there are remedies, even if you've already had different measures of treatment, like prior chemo, surgery, or radiation that didn't work. Now, I'm telling you, there's a guy out there who is clearly the best at this. First tryout or second tryout, that's Dr. Gil Lederman. My personal experience in 1991 is he came up with a remedy for my dad. Others had passed on it or just couldn't figure it out. he was able to save my dad's life, and my family will always, always be grateful to him. But look, if you have newly diagnosed and recurrent